Hi there, my name is Ty Parker and I am a clinical nurse educator in an acute care hospital. Today I will be demonstrating the correct technique for the insertion of a Salem Sump nasogastric tube. The following views expressed in this video are purely that of the individual and do not represent that of any organisation or facility. This video is for educational and instructional use only. Please refer to your own facility's policies and procedures. Please do not attempt anything shown in this video unless you are an appropriately trained and registered health professional. Alright, let's begin. Why are we inserting a Salem Sump? A Salem Sump is used to remove contents and air from the stomach. This could be for abdominal decompression due to bowel obstruction, paralytic ileus, or other GI complications. Salem Sumps are not for feeding patients. If patients require medication delivery or supplemental feeding, then a small white and purple feeding nasogastric tube should be used instead. Inversely, do not ever try to decompress the stomach through a feeding tube. Today we will be demonstrating insertion of a Salem Sump specifically. First of all, let's go through what we will need to conduct the procedure. pH paper for testing once inserted, securement devices, cophenolcane anesthetic spray and nozzle, lubricant, a Toomey syringe, and a Salem Sump nasogastric tube. They come in several sizes, but we will be using the largest, a 16 French. Additionally, we will need blueies, wipes for our table, alcohol gel, and gloves. First of all, we are going to set up our trolley, utilizing the hand sanitizer for good hand hygiene. Next, we'll use the wipes provided to ensure that we have a clean surface to do our procedure. First, we are going to open our size 16 French tube onto the trolley. Leave the tube within the packet until needed. Next, we assemble our cophenolcane spray and nozzle. Both the spray and the nozzle come separately and must be attached to each other. Next, remove a strip of pH paper and place it on the trolley with the container. After this, put out the rest of our equipment, including securement device, Toomey syringe, and lubricant. Set up our patient in high Fowler's position, as high as the patient can tolerate. This ensures ease of insertion and also reduces risk of aspirating when inserting. This procedure can be quite uncomfortable for the patient and often results in the patient vomiting. To protect the patient and bed linen, lay down a protective layer of blueies. If the patient has a stomach full of contents that is not passing through, this vomiting can be quite dramatic, so ensure you have prepared appropriately. That may be one too many. That's a better spot. Salem Sump has several different parts. The tip has several perforations to allow gastric contents to flow into the tube. Along the length of the tube is markings in centimeters with numbers for easy reading. Next is the adapter section that allows the tubing to be connected to wall suction if needed. As you can see, there is two lumens, one for contents and one for air. The blue side tube allows air ingress in order to achieve suction and ends in a one-way air valve. Note, not every tube will come with an air valve attached already, and these are available separately. When not in use, the tube can be plugged into itself as shown. If the one-way air valve is to be added, ensure the blue section is plugged into the blue air port and not the other way around. This allows air ingress into the tube. Before the procedure, use the cophenolcane to numb the patient's nasopharynx for comfort. The nozzle must be primed before use. Be careful not to accidentally spray yourself or others in the face when priming the nozzle. Once primed, insert the nozzle approximately halfway into the patient's nose to ensure you're reaching the nasopharynx, and spray 2 times on both sides. It is not necessary to numb inside the mouth, or any other part of the patient for that matter. Gain informed consent and explain to the patient that this procedure is invasive and uncomfortable. Make them aware that they may vomit, gag, cough, and the other complications that may arise. Now that you have successfully scared your patient, it is now time to begin the procedure. First, we must measure the length of insertion to ensure that the tube will be located in the stomach and not fall too short or be placed too far. Locate the bottom of the sternum, also known as the xiphoid process. This will be our starting point. Place the tip of the tube at the xiphoid process, measure from here to the tragus of the ear, and from the tragus to the nair where you will be inserting. When choosing the side for insertion, ask the patient if they have had previous surgeries, injuries, blockages, or abnormalities to any nostril in particular, or if they have one side that they know is better than the other. Note that we have sprayed cofenalcaine down both nostrils, just in case we are unable to place the tube down one side, then we know that we are already prepared. Note the number of centimeters when measuring and insert to this length. Place lubricant on the tube packet and lubricate the end of the tube. Ensure that you are wearing the appropriate amount of PPE, as the procedure can get messy. Always stand to the side of the patient to reduce exposure to vomitus. Grab your NG tube and begin insertion. Insert the tube along the floor of the nasal cavity. Ensure you are staying flat against the anatomy and not trying to aim up or down. As a guide, aim the tube from the nair internally towards the tragus of the ear. Once again, this is a nasogastric tube, not an orogastric tube, or the unknown tracheogastric tube, so ensure it stays in the nose. Insert the tube into the nasal cavity until you reach the nasopharynx. Sometimes you may need to hold your patient's head for stability and to ensure they don't run away. Once you have reached the nasopharynx, explain to the patient that you will count to 3 and then say swallow. When viewing the patient swallow, advance the tube. Repeat this step until you reach your measurement. If you encounter difficulty, rotate the tube as you insert or aim the tube towards the angle of the mandible as you insert. Sometimes it can be helpful to use water to allow the patient to swallow more easily. If so, instruct the patient to take water into their mouth and hold it, swallowing it on the swallow command. Note that you are unable to do this if the patient is nearby mouth or has dysphagia. I have found that often patients can cough and splutter during the procedure, so introducing water creates an added aspiration risk. So I only utilize this if I have no other option. Ensure a smooth, determined approach when inserting. We want to take the least amount of time as possible to insert the tube without being too aggressive. Going too slow prolongs the procedure, making it uncomfortable. The rate shown here is a good guide at how fast and firm to insert the NG tube. Once at our measurement, we can test to see if we are in the stomach. Attach a Toomey syringe and aspirate some stomach contents. Note that stomach contents will not be clear and will be more a shade of green to black, as shown in this following picture. Secure the tube to the nose using either a pre-made securement device or one made from Hyperfix. On both selections, one strip is placed down the tube and the other is wrapped around it. Never use harsh tapes such as elastoplast, as these are not appropriate for the skin of the face. Here we can see an example of the use of hyperfix. A strip is cut down the middle to make it look like a pair of pants. Test our gastric aspirate using the pH paper. Our stomach contents should be acidic, less than a pH of 5. Note that medications such as PPIs can interfere with this reading. If you are unable to get an appropriate pH reading, then confirmation of placement should be obtained via X-ray. Best practice states that X-ray is the definitive way of determining accurate placement. There are a few other unreliable methods for testing to see if the NG is placed correctly. Pushing a 2 syringe full of air into the patient's stomach quickly and listening to the pop with a stethoscope was once used, but has been shown to be inaccurate as many staff report inconsistencies with being able to hear the noise. There are 2 main areas the tube may go if not inserted into the stomach. Either the tube has entered the lungs, which usually results in continuous coughing and respiratory distress. If this occurs, please remove the tube immediately. Or, the tube has curled up and come out the patient's mouth. If this occurs, remove. Change your angle of approach and attempt to insert again. Lastly, secure the tube to the patient's gown by adding a piece of hyperfix and a safety pin. Congratulate your patient on a job well done. Remember, we are nurses, so ensure you clean up appropriately, placing blueies and solid items in the garbage and linen skips respectively. Thanks for watching. If you liked what you saw in this video, please subscribe for more educational content. What other educational videos would you like to see made? If you have any ideas, please comment below. Thanks!